Hi, my name is Adam Levin in the Department of Orthopaedic Oncology at Johns Hopkins University. We know that a personalized care plan that suits each individual patient is the key to our clinical success. We partner closely with our colleagues across Johns Hopkins to advance patient care, both for now and for the future. We know that patients with advanced disease from a number of malignancies may have a high risk of developing bone metastases, and that these can put the patient at high risk for fracture. Take this gentleman, for example. He presented with some vague discomfort in his thigh in the setting of multiple myeloma. His radiographs demonstrated diffuse skeletal involvement. Note here that there's a number of areas of cortical thinning in the anterior cortex of the right femur, which appeared to place him at high risk for fracture. However, we have noted that in many of our myeloma patients with appropriate treatments, we can mitigate that risk without operative treatment. In fact, when we look back at his images over 4 years earlier, we can see that these really haven't changed over the course of time. Perhaps he really isn't at as much of a high risk as we thought. So we started to look back at some of our own patients. Who presented with fracture? Who did not? Who did we feel compelled to operate on? Who did we watch? In the end, we were able to stratify patients by risk factors, developing a predictive scoring system specific to myeloma bone disease. We took this a few steps further. Together with our brilliant residents and colleagues from radiology and civil engineering, we're able to develop a mechanical model using CT-derived finite element analyses to predict the bone response. Our multidisciplinary efforts with radiation oncology, medical oncology, to identify patients at risk and implement mitigation strategies have greatly improved our outcomes and our ability to avoid unnecessary surgery. Our efforts in developing the musculoskeletal tumor registry, as well as Dr. Forsberg's work with the International Bone Metastasis Registry, will undoubtedly present opportunities for further understanding and advancements in the field. Ultimately, this work has really helped us understand which patients are optimally treated with prophylactic intramedullary nail, which nails may need augmentation with PMMA, which patients are better suited for arthroplasty, and whether those should be long-stemmed or short, cemented or press-fit, and when a larger reconstruction may provide the best long-term functional restoration. Though sometimes we recognize that despite its appearance and Borel score, this large lytic lesion in the mid-diaphysis is just not likely to fracture in this patient's lifetime, and this one can be treated non-operatively. Thank you very much.